Welcome to part 2 of the Advanced Cardiac Life Support Clinical Learning Experience modules. This module will cover arrhythmias and ACLS. This is a crucial area in critical care where understanding the rhythm on a monitor can be the difference between life and death for our patients. The goal for you is to become more confident in identifying, interpreting, and acting on these rhythms in real time. Before we jump into the arrhythmias themselves, let's set our objectives. Today, we'll be identifying and differentiating the arrhythmias that are critical in the ACLS scenarios. We'll interpret rhythm strips, understand clinical significance of each, and explore how to conduct thorough nursing assessments. Most importantly, we will discuss how to implement and prioritize the necessary interventions quickly and effectively. Keep these objectives in mind as we go through each rhythm because everything ties back to these key points. Okay, so first let's talk about EKG versus ECG. Those are two terms that refer to the same thing, an electrocardiogram. The difference lies in the abbreviation. So the EKG derives from the German word electrocardiogram, where the C sounding names, the K, are actually spelled with a K. While ECG comes from the English word electrocardiogram, but with the C or the K sounds are C's. So basically, it's just different spellings of the same word. So both terms are used interchangeably to describe the process of recording the electrical activity of the heart over a period of time, which is essential for diagnosing various heart conditions. In clinical practice, ECG is more commonly used, but EKG is still prevalent and in some contexts, but especially in historical like European settings. I will let you know in the ER, I hear EKG more than I hear ECG. So a cardiac monitor is a device used in hospitals, clinics, or ambulances to continuously observe a patient's heart activity. It typically uses 3 to 5 electrodes placed on the patient's chest, which provide a real-time continuous single lead or multiple lead ECG tracings. The purpose of a cardiac monitor is to observe the heart rhythm, detect arrhythmias, and monitor the overall cardiac function in real time. So this is like watching a live stream video of what's going on in the heart. This is commonly used in the critical care units, emergency departments, and during surgeries to monitor a patient's heart. So the 12-lead ECG provides a more comprehensive assessment of the heart's electrical activity by recording electrical impulses from 12 different angles. Sometimes we also refer to this as leads, the lead or the angle in which the electricity is coming from. These 12 leads provide a complete view of the heart's electrical activity from different perspectives, which helps in diagnosing conditions like myocardial infarctions, ischemia, and various arrhythmias. The 12-lead EKG is typically at like a snapshot, like a photo of just a time period rather than a continuous monitoring or like a live stream video. And it's commonly used in the diagnostic setting. The leads are attached to the patient's limb and chest in specific positions, creating detailed pictures of the heart's electrical activity. So EKG and ECG, these pictures on the screen, you can see these are the different placements of the leads. So the one on the left-hand side is a good picture of like when you have like a 5-lead continuous heart monitor. Now, sometimes there are 3 leads as well. The one on the right, the picture on the right, now that's where we place for a 12-lead EKG. And you can see there's a whole lot more stickers or electrodes that we place. It's important that you guys know where to place all these. And so look it up in your textbook if you're not already aware. But should be quick. Now there's like some little terminologies that a lot of people do, like the clouds over grass, smoke over fire, and the brown in the middle for like the 5-lead. Now, sometimes you have a 3-lead heart monitor, and that one is I've always learned it as salt, pepper, ketchup. So salt, pepper, white, black, ketchup. It just goes that way. And then I always just throw the green. If there's extra, there's green or brown. That's just how I've always done it, but you can do it whichever way you want. So what exactly are you looking at when you get this printout from a 12-lead EKG? So each one of these areas, if you could look on the left-hand column, there's leads 1, 2, 3. The second column, AVR, AVL, AVF. Then the third column, V1, 2, 3. The fourth column, 4, 5, 6. And then at the bottom, you see it says rhythm 2. So it's taking that second lead from the first column, and it's just doing a longer strip at the bottom. Okay. So when you look at this is like seeing from different angles of the heart. What's going on in the electrical impulse through here? Yes, it does measure stuff at the top for you, which is very nice, so that you don't have to do it old school style with calipers. And a lot of times it will have interpretations up there. It will say like acute STEMI or, sinus Brady. It like kind of interprets the EKG for you, but don't always trust that. You always get a physician. As soon as you get these done, a physician needs to see it, review it, an expert to basically identify if there's anything life-threatening on it or not. So EKG, so this is kind of what I was just talking about. So when you look at an EKG report or choose a lead on the cardiac monitor, so like a lot of times the cardiac monitor is like lead 2, okay? Think of each lead like a camera that's pointed in a different direction around the body that goes like through the heart. So imagine you're a photographer trying to capture the perfect picture of like a landscape, but instead of the landscape, you're photographing the heart's electrical activity. Each lead or camera is positioned at a different angle around the heart, capturing a unique view of that electrical impulse as it travels and moves through the heart tissue, okay? For example, in a 12-lead ECG, you have 12 different cameras all pointing around the heart from various perspectives. Some cameras are placed on the limbs, giving a broad view of the heart's electrical activity from different directions, while others are placed on the chest, providing close-up shots of specific areas of the heart. Together, these cameras create a comprehensive picture, like an overall from around the top, the bottom, the sides, helping us to understand exactly what's going on in the heart and how it's functioning. So when it comes to cardiac monitors, most healthcare providers select lead 2 as the default view. So when you see a heart monitor, you'll see typically like one line of a heart rhythm, okay? You can tap on it and switch to a different lead. I don't know if you know that, but you can. Often they're preset for lead 2, and you might ask yourself, why is that? That is because lead 2 captures a view that aligns well with the natural like flow of the electricity of the heart, particularly along the pathway from the atria to the ventricles. This angle is ideal for detecting common rhythms and arrhythmias, making it like a legit reliable choice for continuous monitoring. Doesn't have to be lead 2, but that's typically what people choose. So when you're analyzing an ECG or deciding which lead to monitor, remember, you are essentially choosing which camera angle will give you the best view of the heart's electrical activity at that moment. And lead 2, it's the photographer's favorite lens. It's kind of the way to say it. It's versatile, clear, and perfect for catching the most important details. So you may have counted how many cameras are on that picture on the side, and you may have said, wait, you keep calling it a 12-lead EKG, but I only count 10, and you only do 10 little sticky pads on the patient's chest. So what's going on? So this is just kind of for your own information, but the term 12-lead ECG can be misleading because it refers to the number of different views or leads of the heart's electrical activity that the ECG machine, not the number of physical electrodes placed on the patient. So basically how this works is when you're performing a 12-lead ECG, you place 10 electrodes on the patient's body. There's going to be 4 on limbs. So your right arm, right leg, left leg. Okay. And then there's going to be 6 electrodes placed on the chest. Now, do sometimes people place those limb leads on the chest and like lower abdomen? Yes. Are they supposed to be on the arms and legs? Yes. But can you still do it on the chest and like upper, like clavicle area, not on top of a bone? Technically, yes. But it's better if they're on the limbs. Okay. So the 10 electrodes work together to create 12 different leads or views of the heart's electrical activity. Okay, so how this kind of comes together is there's 3 standard limb leads. That's lead 1, 2, and 3. By the way, side note, don't stress about memorizing what I'm talking about right now. This is just purely so that you understand what you're looking at. You will not be questioned on this. You just need to kind of have an understanding of what you're looking at. That's different angles, and you can stop there. But this is just kind of for your own information. Now, if you go work in the ICU or you're on a cardiac unit, you want to go be an advanced practice nurse, especially if you are even thinking for a hot second about being a CRNA, an ER nurse, an OR nurse. This is very beneficial information, but it's not necessarily needed. But I guarantee if you go in the ICU, especially a CV ICU, you're going to know this. Okay, back to how the 12 leads are made up. Okay, so there's the 3 limb leads, lead 1, 2, and 3. They're generated by combining signals from the limb electrodes. So all 4 limb electrodes, kind of the machine computes it, and it comes out with lead 1, 2, and 3. Now, there's 3 augmented limb leads. That's the AVR, AVL, and AVF. So the first 2 columns on an EKG printout are coming from your limb leads, okay? So those are calculated a little differently by the ECG machine, but they give you a little additional views. And then the 6 precordial leads. So those precordial, or like another word for that is like the chest area, okay? So those are the V1, 2, 3, 4, 5, 6. So those each represent a view of the heart's electrical activity up close from the chest electrodes. So the reason you only need 10 electrodes to create 12 leads is that ECG machine is mathematically combining the information and the signals from the 4 limb leads that generate 6 views on the paper, if that makes sense, okay? So the chest electrodes directly produce the 6 precordial leads, but this approach, the way that this works, it allows for the detailed, comprehensive view of the heart and the electrical activity without requiring 12 separate physical connections to the patient. So let's reminder of the ECG waveform, a review. Okay, so when you're reviewing an EKG ECG waveform, you're looking at the heart's electrical activity displayed in a series of waves and intervals. Each part of the waveform corresponds with a specific phase of the heart's electrical cycle. So you already should know everything on this page, just FYI. This should be a straight up review, but I just want to go over it just to make sure that we're all on the same page. Okay, so the P wave. What is the P wave? The P wave represents atrial depolarization. So what is that? It's kind of a fancy long word, and I know students will often kind of get a little flustered. Depolarization, repolarization, what's exactly going on? So the P wave is atrial depolarization. So that's when the electrical activity that triggers the atria to contract. When something contracts, it squeezes. So basically that's the electricity going through the atria to make the atria squeeze all the blood from the atria into the ventricles. Okay. It's usually a very small rounded wave that comes first in the cycle. A normal P wave indicates that the electrical impulse is starting from the SA node in the heart's natural, which is that heart's natural pacemaker, okay? That's where we want it to start. That's where it's meant to start, okay? The PR interval is the time between the onset of the P wave and the start of the QRS complex. This interval reflects the time it takes for the electrical impulse to travel from the atria through the AV node to the ventricles. A normal PR interval suggests that the conduction pathway is functioning properly. So the QRS complex, that represents ventricular depolarization, or the squeeze of the ventricles, okay? This is typically the most prominent, biggest part of the whole entire waveform. The shape and width of the QRS complex can provide important information about how the electrical impulses are traveling through the ventricles. So the ST segment. ST segment is typically a flat isoelectric line that's right after the QRS complex, but comes before the T wave. It represents the time when the ventricles are depolarized and preparing to repolarize. So any elevation or depression in the ST segment can indicate issues such as myocardial ischemia and infarction. Typically, depression is ischemia, elevation is infarction. Not always the case, but typically that kind of goes with it. So the T wave itself, it represents the ventricular repolarization. So that's the process by which the ventricle is resting. So like it's no longer getting shocked by a piece of electricity and squeezing. It's now opening and relaxing and filling basically back up with blood, right? So, and it's that during the T wave, that's when it's preparing for the next basically electrical jolt that will cause a squeeze and a contraction. A normal T wave is usually upright and just slightly rounded, okay? Abnormalities in the T wave can indicate issues with the heart's recovery phase, such as electrolyte imbalances or ischemia. I know like your heart muscle is super, super particular about potassium, but it also other things too. So when your potassium's high, that T wave is going to be peaked. It's going to go be way up high and then come down low. That's sure sign right away. They're like, oh, something wrong with the kidneys. Is something going on here? Whatever. Just looking at the cardiac monitor. Okay. The QT interval. So the QT interval measures the time from the start of the QRX complex to the end of the T wave. This interval represents the total time it takes for the ventricles to depolarize and then repolarize. A prolonged QT interval can be a sign of an increased risk for arrhythmias. So do not just turn your head and walk away. Just kind of make note of that, okay? So understanding each part of the ECG waveform is super important for interpreting the electrical activity of the heart and identifying those potential abnormalities. Each part of the wave and the intervals provide critical insights into the timing, direction, efficiency of the heart's electrical impulses. It tells you so much about what's going on with the heart without even getting lab work back. Okay, so now let's start talking about the fun things, identifying rhythms. We're going to start out with the fun one. Ventricular fibrillation, which we also call that VFib or VF, okay? So VFib is one of the most critical arrhythmias you're going to see and encounter as a nurse. On the monitor, VF looks very chaotic. It's irregular waves. It's like just kind of blah, 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 all over the place. It's kind of fancy term there, blah, blah, blah. Okay. On the monitor, you're going to not be able to see any discernible P waves or QRS complexes. It's just going to look like a toddler just scribbled, like some nonsense on the screen. Okay. It's what it represents is the ventricles are quivering. They're just like kind of just shaking it around. They're not actually doing a full great squeeze to actually get the blood out. So now, if the ventricles are just quivering and they're not actually squeezing, do you think the blood is actually leaving the heart and going to the body? The answer would be no. That means there's no effective cardiac output when a patient is in VFib. Okay, so ask yourself, is this an emergency? The answer would be yes. This is definitely a medical emergency, and without immediate defibrillation, the patient's not going to survive. Okay, this is not a let's turn around and walk away. This is a do something. Okay, so VFib is the most common cause of sudden cardiac arrest, and time is absolutely of the essence. As a nurse, our role is to recognize this immediately, call for help, and prepare for defibrillation. The survival rate drops significantly every minute defibrillation is delayed, so act fast. Now, I'm going to note on this, okay? You need to defibrillate this person, ASAP. But let's just say you're in the room, there's no code cart nearby. What are you going to do? There's no pulse, right? Because there's no cardiac output. If you answered you're going to start chest compressions, yes, you're going to call a code blue, start chest compressions, wait for the code cart to arrive. Now, that's kind of like if you're on a med surg unit, okay? If you're in the ICU, you should probably already have one nearby. ER, same thing, but you'd still start CPR until you're ready to go. Now, if the patient is already hooked up, already has the pads placed on the chest, you've been monitoring them, and all of a sudden you see VFib, you're going to go straight to the shock, okay? That's what we need to do, okay? Okay, so now let's talk about VTAC. So ventricular tachycardia, or VTAC, is another life-threatening rhythm that you're going to need to recognize as soon as possible, okay? So one of the main characteristics of VTAC is a wide, regular QRS complexes. So if you look on the screen, they're all regular. They all look kind of uniform, but they're wide, right? Okay, some people will say these look like tombstones because it's basically telling you what's about to happen if you don't intervene, okay? So it can present with or without a pulse. And that is very important for you to know if they have a pulse or not, because that's going to determine what you do next, okay? If the patient is stable and has a pulse, they probably will not have a pulse for long, but if they have a pulse, you might be able to give meds to fix this, okay? You have just a smidgen of time, but you have a little bit of time. But if they're unstable and pulseless, okay, obviously you need to defibrillate immediately. But just like with VFib, if they're unstable and no pulse and there's no AED nearby, you start compressions until the AED gets there. If the AED is right there, you defibrillate first. I hope that makes sense. Okay. Because what they need is a shock before their heart stops, okay? So there's still a little electrical activity going through here, but the heart is not able to pump And so we're not getting blood anywhere. And so it's only a matter of seconds, maybe minutes, before the heart stops. So we need to shock it to get it back into a normal rhythm before it stops. Okay. So V-tach is commonly seen in patients with underlying heart disease. So keep an eye out for this rhythm in your cardiac patients. Okay. And also remember, the key is to assess the patient first. Don't just rely on the monitor. We treat the patient, not the monitor. If you see this on the monitor, you need to look at the patient. Okay. Obviously, hopefully the patient's awake, but if they're not, obviously follow the steps in ACLS. So next is asystole. You all probably know what asystole is, but let's just go over it real quick. So it is often what we refer to as a flat line. There's absolutely no electrical activity in the heart and the patient will have no pulse. This is an emergency, and one with immediate action can still make a huge difference. The first thing you're going to do is actually confirm that the rhythm isn't truly and in fact asystole. Why do I say this? Because you might see this on the monitor and it's just because the electrodes came off the skin. The patient may have been sweaty or they may have pulled them off. So like we don't just immediately assume and start chest compressions. Remember, like we need to just check a quick pulse and then start like really quick, but you can tell, okay? They're probably going to be a little pale and dusky too because they don't have a pulse. But anyways, so you're going to first confirm that it's truly asystole, and you're going to make sure the leads are in place. And then what you're going to do, so the other thing is asystole also might look like fine, like very little teeny tiny VFib. Okay, so we just talked about VFib, and it may not actually be like a straight line. It may just be like just teeny tiny little up and down VFib. So if it's fine VFib, you need to obviously go into the algorithm for VFib. You need to shock them or start CPR. But if it is in fact asystole, you cannot shock it. Okay, you cannot shock something that has no electricity going through. So asystole is not a shockable rhythm. I don't care how many Grey's Anatomy episodes you've watched where you saw a flat line and they're like, clear, shock advised. No, doesn't happen. That's Hollywood. You cannot shock asystole. Say it with me again. You cannot shock asystole. Okay. So once you confirm it's asystole, you start that CPR immediately. Okay. So it's not shockable. Defibrillation will not help. Instead, you need to focus on that high quality CPR and administer medications like epinephrine to try to stimulate some sort of electrical activity again. And hopefully you do that. So now we're going to talk about pulseless electrical activity, or PEA. I don't have a rhythm on this page because it could look like anything. Okay, so here's the clue. Anytime you get a strip and it looks like there's a pulse up there, but you go and assess the patient and there's no pulse, it's pulseless electrical activity. Okay. So what PEA is when you see an organized rhythm on the monitor. So it looks like a rhythm, but the patient has no pulse. What that means is that the heart's electrical system is working, but somehow something's not translating completely into the actual mechanical contraction and squeeze of the heart. So blood isn't moving throughout the body, okay? So there is some electricity going through the heart, and so the monitor looks like it's okay, but the actual squeeze isn't happening in real life, so there's no blood pumping. So PEA is the other non-shockable rhythm. You cannot shock PEA or asystole. Won't help. Okay. Instead, you're going to need to start CPR immediately and identify the reversible causes, often referred to the H&Ts, and we're going to go over that more in the last module. But for just a few examples, like that's hypoxia, hypovolemia, hypothermia, tension pneumothorax. Like those are some of the things that could lead to PEA or some other issues with the heart. But anyways, correcting those underlying causes is the key to treating PEA. But you're going to be doing CPR until you figure out what's wrong. Okay, so now let's talk about AFib, or atrial fibrillation. So AFib is one of the most common arrhythmias, and you've probably had a patient with this before. Maybe you even know somebody, okay, that you're, as a nurse, that you're going to encounter, okay, especially in older adults. It's characterized by an irregular rhythm with no distinct P waves. Okay, so it's irregular, no P waves. While AFib isn't immediately life-threatening, it does carry some significant risk, which the big one is thromboembolism. So you can throw a clot real quick, and that can lead to a stroke. The main goal in managing AFib is controlling the heart rate and preventing clots with anticoagulation therapy. In some cases, cardioversion might be necessary to restore the normal rhythm, but that's not common. And it depends on some other factors. So don't focus on that. With AFib, you see it's just kind of like the atrium are just like kind of shaking and kind of quivering. So it's not really getting a good full squeeze from the atrium to the ventricles. And so because of that, when it kind of quivers and doesn't get a full squeeze where it gets all the blood out of the atrium into the ventricles, that blood some blood may just kind of hang out and swirl around until the next squeeze. And anytime the blood hangs out, even for just like a millisecond, it's going to start to stick and clot to one another. So that's why this is at risk for clots forming. So now A flutter, similar but different. A flutter is similar to the AFib, but it has a little bit more of an organized pattern. So it's a little bit more consistent between each QRS complex. Okay. People often use the term sawtooth to describe those waves between the QRS complexes. It's going to represent a rapid, regular atrial contraction that doesn't always lead to a corresponding ventricular contraction. So remember, ventricular contraction is going to be the QRS. So you see every time those little sawtooths go on, there's not a QRS right behind it, right? So those sawtooths are like P waves. It's like P wave, P wave, P wave, QRS, P wave, P wave, P wave, QRS kind of thing like that. So how you manage a flutter is similar to AFib. You're going to control the rate and do anticoagulation, okay, therapy. You might need a cardiovert, but it's, again, depending on the situation. So while this may not be as common as AFib, it is super important to recognize the pattern because the treatment and approach is similar. So bradycardias. So there's a whole bunch of them. We're going to go over a couple of them here in a minute. You may have already learned these, and if you have, go you. If not, go along for the ride. Okay, so bradycardia in simplicity form, it just means that that heart rate is less than 60 beats per minute, okay? You can have sinus bradycardia, which is just like everything is normal except for the rate. It's just lower than 60. But then you have some other bradycardias that are because there's some blocks, and we call it AV blocks. You have first, second, and third degree. In the second degrees, you have type 1 and type 2. So we're going to go into this more here in a second, okay? The key with the bradycardias is to assess whether the patient is symptomatic or not. Are they dizzy? Are they lightheaded? Are they having chest pain? If they are symptomatic, you'll often start with atropine as a med to help stimulate the heart rate. If that doesn't work, you move on to transcutaneous pacing. So transcutaneous pacing is the same things that we just deliver defibrillation shocks through, but it just sends like tiny little jolts at the same time that your heart should be beating. And we can actually set that on the cardiac monitor. We can set it for 60 or 50 or whatever we want. And so it will capture and actually cause a little electrical heart to make sure that the heart stays beating at the right rate, okay? They can also go in surgically and put a pacemaker inside, but we can do it on the outside temporarily as for transcutaneous pacing. So when you are pacing a patient, always monitor them super closely. You're not going to be, like running off for hours, obviously. So because a lot of times those bradycardias can progress into more serious blocks, especially if you leave them untreated. And so you kind of need to go to more definitive treatment. So now we're going to talk about first degree heart block. So identifying a first degree AV block on the EKG is straightforward if you actually know what to look for. So a simple way to do it is the first thing you're going to do is find the P wave and the QRS complex. Okay. So find the P and the QRS complex. The PR interval is the space between the start of the P wave and the start of the QRS complex, right? So normally it should be between 0.12 and 0.20 seconds. So normal is between 0.12 and 0.20 seconds. In a first degree AV block, the PR interval is longer than 0.2 seconds. So it's a little bit longer between that squeeze of the atrium and to the squeeze of the ventricles, okay? So this means it takes longer for the electrical signal to move from the atrium to the ventricles, but the signal is still getting through every single time. So it is considered a consistent rhythm. So there will be a P wave for every QRS. Even though the PR interval is long, it stays the same for every beat. Each P wave has a QRS followed behind it. So this is first degree. There is a P wave and a QRS for every one. There's no missed beats. So just to summarize it again, first degree AV block is identified by a long PR interval, which is over 0.2 seconds. That remains consistent with a regular heart rate and rhythm. So now let's talk about second degree. So there's two different types of second degree heart blocks. There's type 1 and type 2. You'll also hear type 1, Mobitz type 1, Mobitz type 2. And another name for the type 1, you might also hear Winky Bach. It's a fun word, right? So second degree type 1, Mobitz type 1, Winky Bach, all the same. Second degree type 2 or Mobitz type 2. So those are the same words, synonymous. Okay. So the second degree type 1 block. In that one, you're going to notice that the PR interval gradually gets longer with each and every beat. So it's a little long, then a little longer, then a little longer, then a little longer until one of those beats is eventually dropped, which means that a P wave is not always followed by a QRS complex. So if you look at the top picture, you see a PQRST, 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 and then a P, and then nothing, and then another PQRST, and then another PQRST. And if you notice the space between the P and the QRS complex, it gets a little bit longer with each one. That is second degree type 1. Okay, so type 1 is often less serious and can be seen in healthy individuals, especially during sleep. It's usually due to a delay in the AV node and often doesn't require treatment unless the patient is symptomatic. Now, type 2, a little bit more serious than type 1. The PR interval is consistent and does not progressively lengthen. So look at all of those. So you see the PR interval is about the same between the P and the QRS, right? They're about the same length for each one. Okay. However, some P waves are not followed by a QRS complex, kind of similar to the first one, but the difference is it's not like slowly lose a beat. The second one is the same, and then all of a sudden, just for some odd reason, we don't have a QRS, okay? So that means that the electrical signal from the atria to the ventricles is just suddenly blocked for whatever reason. It's just a random dropped beat. So unlike with the type 1, the drop beats in the type 2 are just unpredictable and just randomly occur. The PR interval remains the same before and after the dropped beat. Remember that. So it is a little bit more serious and a little bit more concerning because it often indicates a more significant problem with the actual, like what's going on with the heart and the conduction system, particularly below the AV node. It can progress into a more serious block, like a type 3 complete block, and it typically requires treatment such as a pacemaker. So just to summarize that again, type 1, also known as Mobitz 1, the PR interval gradually lengthens leading to a drop beat. Then the cycle repeats. In the type 2, which is also known as Mobitz 2, the PR interval remains constant, but beats are just randomly dropped, making it more serious and often requiring intervention. So you need to be able to understand the difference between these two and identify them. So now third degree heart block. So with third degree heart block, it's also known as a complete heart block, and it is definitely the most serious type of AV block. So some of the things that you need to know is there's just no communication between the atria and ventricles. They're both doing their own thing. It's basically like husband and wife not talking to each other. Like, I'm going to do my thing, you do yours, and we'll just figure it out later on. That doesn't work well, just letting you know. So in a third degree block, the electrical signals from the atria are completely blocked from reaching the ventricles. This means that the atria and the ventricles are beating independently of each other with no coordination whatsoever between them. So the P waves and the QRS complexes are independent. If you look on the screen, there's just like these little bitty, tiny, not very high P waves, and then you can see the QRS complexes. So it's like the P waves are doing their own thing, and the QRS is just kind of like farther apart, okay? So with that said, the P waves are marching at their own rate, controlled by the SA node, but the QRS complex are marching at a slower independent rate because they're usually controlled by some pacemaker cells within the heart, lower in the heart in the ventricle area, like the AV node or ventricles. So SA node is doing its thing for it's helping out the atria, but like that pulse doesn't keep going to the ventricles. And so another piece of the heart is generating a pulse that actually goes through the ventricles. Okay. Because the ventricles are not receiving those signals from the top, from the atria, they're relying on those secondary pacemaker cells in the heart. So those secondary pacemaker cells, they normally typically fire at a much slower rate, like between like 30 and 40 beats a minute. The slow rate can lead to symptoms like dizziness, fatigue, syncope even, like they could be passing out. So if the ventricles are being paced from a site within the ventricles themselves, so like if the ventricles are like the electricity going through the ventricles is coming from a piece of heart tissue within the ventricles. The QRS complexes might be wider than normal. So that just basically is telling you that the electrical signal is traveling through the ventricles slowly because it's wider. It's taking more time for the, QRS to happen. So that means that the electrical signal is just moving slowly. I hope that makes sense. So this is a definite medical emergency. Third degree block is medical emergency. And without coordinating that electrical activity, the heart can't pump blood effectively, and it's going to lead to more severe symptoms requiring immediate intervention. It's often going to lead to a permanent pacemaker being put in. Okay, so just to summarize, in a third degree AV block, the atria, parts on top, and the ventricles are beating independently. There's no communication between them. What you're going to see on the EKG is you're going to see a P wave and a QRS complex that are regular, so they're happening kind of at the same, like the P waves are happening pretty consistently, spaced apart consistently. Same thing with the QRXs, but they're completely out of sync with each other. And so remember that this requires urgent treatment. So SVT, we've already kind of talked about this in class, but SVT or supraventricular tachycardia is a rapid, narrow, complex tachycardia. Okay, so rapid, narrow, complex tachycardia that often presents with a heart rate between 150 and 250. So it's going to have a high heart rate. Like I typically see these like 180, 190, 210 kind of thing. So patients are going to complain typically of palpitations, dizziness, shortness of breath, anxiety, chest pain, like they can't catch their breath, those kind of things. So the first line of treatment is often a vagal maneuver because the patient can do that on their own without an IV, without anything. So vagal maneuver is bearing down. So like a Valsalva maneuver. So if that doesn't work, then we can give adenosine. Remember adenosine, like adenosine, it's just like a stop sign, like stop for just a second and then proceed slowly. So it's the drug of choice that rapidly will convert the rhythm back to normal, hopefully. It's important to recognize that SVT as early as you can and intervene because while it's not typically life-threatening, it can lead to more serious conditions and your heart can eventually stop if you leave it untreated. Now, with adenosine, you can give it multiple times. And sometimes the first time it doesn't work. And so we're going to double the dose the next time and go read up on adenosine again about like the average milligram strengths and stuff like that for how you give like first line, just to refamiliarize yourself with it. Okay, so now let's talk about torsades de pointe. So a lot of people just call this torsades for short. Okay, what this is it's a specific type of polymorphic VTAC or ventricular tachycardia. It's characterized by a twisting QRS complex. So it kind of looks like an accordion to me. It gets bigger and smaller, bigger and smaller. Okay, so this is often associated with prolonged QT intervals, which can be caused by certain medications, electrolyte imbalances, or even sometimes congenital heart conditions. So the treatment of choice for this is magnesium sulfate, which can help stabilize the heart's electrical activity. If you see torsades, you need to think immediately magnesium. Torsades, magnesium, torsades. Put those two together, you see torsades where it gets bigger, smaller, magnesium, okay? So without treatment, torsades can quickly turn into VFib, and so it's important that you give that mag and you act fast. Also, if you just monitor electrolyte levels, particularly potassium and magnesium, that can help to prevent this from even happening. So we want to pay attention to those electrolytes. They're important. Now, sinus tach. You probably have already learned about sinus tach when you learned about normal sinus rhythm and sinus bradyia back in like med-surg. But it's important to put here for a few reasons. So sinus tach is a fast heart rate, generally over 100 beats per minute, but unlike other arrhythmias that we've discussed, it's typically normal physiological response to something else going on in the body. So some of those things is like stress, illness, fever, dehydration, pain. All those things can make the heart rate go fast, right? So the key here is to assess and treat the underlying cause rather than just trying to slow the heart rate down. So, for example, if the patient is dehydrated, you're going to give them fluids. If they're in pain, you're going to give them maybe pain medication or put them in a different, more comfortable position. So once you treat the underlying issue, the heart rate should return to normal on its own. If it doesn't, then something else is going on. Okay, so Interpreting rhythm strips is super important in the critical care setting. Okay, so whether you're in the ER, ICU, OR, PACU, even on a med surg unit, it's still super important because your patient might be on a telemonitor. Okay, so the first thing you need to do is have a systematic approach when you're looking at a rhythm strip. Okay, you need to identify the my suggestion is first, what you're going to do is you're going to identify the overall rhythm type. Are we dealing with a tachycardia, a bradycardia, or something else? The next thing you're going to do is assess the rate and regularity of the rhythm. So are the beats evenly spaced, or is there a variability between the two? You're going to also look very closely for P waves, QRS complexes, and T waves. Are they all present? Do they look normal? Is one missing? Are they missing systematically, or is it just occasionally? And then finally, you're going to tie it all together by determining the clinical significance of what you're seeing, and always tie it back to how the patient looks, right? We're not just treating a monitor, we're treating the patient too. So you're going to ask yourself, is this rhythm even compatible with life, or does it need something like immediately to save their life? Kind of important to know. So nursing assessments and arrhythmias. When you encounter an arrhythmia, your nursing assessment is your first line of action. You need to start by assessing the patient's symptoms. Are they experiencing chest pain? Are they short of breath? Or are they dizzy? So all those can be signs of poor perfusion. You need to check their vital signs, their blood pressure, their oxygen, their pulse rate, to get a sense of like how the patient's body is responding to the arrhythmia. Are they symptomatic or not? So don't forget to evaluate the patient's mental status as well, because confusion or decreased responsiveness can also indicate a drop in cerebral perfusion, which means they're not adequately pumping that blood through the system. Always don't forget to always document your findings as clearly as possible and accurately, as this is going to guide your next steps in the patient care. So prioritizing your actions during an ACLS scenario is about staying calm, number one, and following a logical sequence. Always assess the patient first. Don't just rely on the monitor. The monitor can trick you, remember? So if you recognize a life-threatening rhythm like VFib or asystole, act immediately by following the ACLS algorithms. And we're going to go over a little bit more of the algorithms next time in part 3. These protocols are there to guide you through the steps in a systematic process, okay? So remember, ACLS is a team effort. You're not alone. You should be coordinating with your team members to ensure that you are all rapidly and effectively intervening, okay, in a systematic and organized way. And don't forget to continuously reassess that patient, because things can change. They could get worse, they could get better, okay? So just be flexible, be quick on your feet, and those are going to be your best tools for helping out patients in a critical setting. The more you practice, the more you become familiar with these rhythms, the more you're not going to be stressed out about thinking, what is a screen? What do I do? I don't know what that is. Do I shock them? Do I do compressions? Do I call? Do I give a med? I don't know. So the more you become familiar with them, the more comfortable you are, the more confident you are, the better you'll be able to stay calm and just think through and respond in a critical situation. So in summary, we've covered the key elements of arrhythmias that you're going to encounter in ACLS and the critical importance of the rapid identification and management of those arrhythmias. Remember to take a systematic approach when you're doing rhythm interpretation, starting with the basics and building up on those to understand how significant the findings are clinically, okay? Your nursing assessment skills are so important in identifying those symptoms and assessing stability, and also guiding you into what interventions you should do. Okay, so throughout all of this, effective communication with your team is also important, and will help make the successful resuscitation and avoid some missed opportunities to save your patient. So remember to stay sharp, go through that systematic process, and always think and put your patient first. So that concludes the ACLS Module 2. Don't forget that there will be an ACLS Module 2 quiz in Blackboard, and to complete it by the due date and time. Remember, it's going to be open book, open note, just not open partner. So it'll be over basic understandings, but also remember, it's going to be more application-based when we get to the exam. So this is just a straight knowledge check. I would definitely start quizzing yourself over those rhythm interpretations. So good luck and happy studying.